Hi all, good morning. Should we wait for some more time for your friends to join, or should we proceed again with the class? Hello? Yeah, Amisha, please tell me. Okay, maybe we'll wait for another a couple of more minutes for your friends to join. We are currently at 40 plus. Maybe once we reach 50 plus or 60 plus, we'll proceed again with the class. Okay, okay. Okay, I think we have waited enough for your friends. I mean, let's proceed again. It's ahead 9-7 already. So Today we'll be in the series of these lectures, discussions on national health programs. We will be taking up non-communicable disease related program for today, right? So, I mean, if you recall the fifth semester lecture on NCDs, we had discussed some of the important points through all the lectures on NCDs. Just trying to recall a few of them for you. There is this common risk factor approach, which I had mentioned almost in every lecture on non-communicable disease taken by me. So there are 4 common risk factors which most of the non-communicable disease are related to, namely the tobacco usage, harmful use of are you still able to see the slides? There seems to be some internet error here. बीच में वो आया था इंटरनेट एरर, इंटरनेट लॉस्ट. ठीक है, मैं कंटिन्यू करता हूँ फिर. So we were talking about the 4 common risk factor approach, which will be very beneficial when we try to address non-communicable diseases as a whole, rather than trying to look at them from each disease point of view, not like diabetes, not separately hypertension, not separately as cancers. I mean, like we do in communicable diseases. We have a separate national program for tuberculosis. We have a separate program for let's say, I mean, the vector-borne diseases. Even there, we have tried to group these vector-borne diseases under one head. I mean, we are trying to deal 6 vector-borne diseases as one joint program. So slowly we are moving towards integration, trying to bring all them together. So in non-communicable disease also, integration is a very important component which has been taken as a programmatic initiative. So for the purpose of this lecture, I have taken liberty of using the slides of Dr. Chinmayi, who deals with non-communicable disease in the Ministry of Health and Family Welfare. These slides we had during the training session in 2018 when I attended in Delhi. So thanks to Dr. Chinmayi for her slides. So there are various national health program initiatives at the moment for non-communicable disease. Slowly we are trying to integrate them. The major program which we will be discussing today is the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease and Stroke. I mean, which is an amalgamation of the program for diabetes, cardiovascular disease and stroke, along with the pre-existing program for cancers, which used to provide tertiary care facilities at various hospitals across the country. That has been brought in together into this, and then a common program for cancer, diabetes, cardiovascular disease and stroke have been launched in 2008. Apart from this, we do have standalone programs still running. Slowly, each of them will be brought into the NBCDCS brackets, namely the National Mental Health Program, National Tobacco Control Program, National Program for Health Care of Elderly, National Program for Control of Blindness, National Program for Control of Deafness, National Oral Health Program, National Micronutrients Program including fluorosis, National Program for Prevention and Control of Iron Deficiency Disorders, National Organ Transplant Program, National Program for Prevention and Management of Burn Injuries. These are some of the other important yet minor programs at the moment standing alone. Slowly each of them will be integrated into a common program, and so today for the discussion we'll be taking up the major program, namely the National Health Program, National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease and Stroke, NPCDCS. Right, so this is the program which we are going to discuss today. So this is again a revision point from our previous theory discussions, that NCDs slowly has evolved and trying to contribute a whole lot of mortality in India. We have also seen about the premature mortality, that death happening between 30 to 70 years of age, in which non-communicable disease is the major contributor. Right. So here also, if we see in these slides, proportional mortality, more than 60% of all the deaths in all age groups are due to non-communicable diseases. So communicable diseases, maternal causes, perinatal, nutritional conditions, which used to be the major cause of contributor to mortality in India in the earlier decades, is shrunken to nearly almost 1/4 or 28% of all the deaths. But if you see the remaining all cardiovascular diseases contributing 1/4, chronic respiratory diseases about 13%, diabetes, cancer, NCDs, all significant contributions, and quite a significant contribution is also from the injuries. So these NCDs all put together is now taking up a big chunk of the pie when we consider proportional mortality rate in India. Right, so that we have already seen in our theory lectures in 5th semester. So this is what we are talking about. I mean, premature death. I mean, anyone dying between 30 to 70 years of age who actually could be contributing to the economy, the family, or the community in active form, die due to any disease. So about 1 in 4 chance of any, I mean, person above 30 to between 30 to 70 dying is due to non-communicable diseases. And rough survey data, if we simplify, some of these figures would look like this. Out of every 10 individual, 1 has raised blood pressure, 2 have raised blood pressure, sorry, 1 has raised blood glucose, 2 have raised blood pressure, 2 are overweight, and 3 use tobacco products. And the major contribution of out-of-pocket expenditure on healthcare is due to non-communicable disease. One of the important component being the chronicity of the disease of non-communicable disease, that they have to spend for their treatment care throughout the life once they acquire a non-communicable disease, in most cases, though not in all. So, I mean, as we had seen, these common risk factors, physical inactivity, unhealthy diet, tobacco, alcohol, and along with stress and various other contributors, jointly work towards to cause all these major non-communicable diseases that we have been trying to. So any prevention and control of non-communicable diseases mentioned above is going to be, I mean, better if we are trying to concentrate on the common roots, namely the physical inactivity, unhealthy diet, tobacco and alcohol, harmful use of alcohol, and stress-related areas. So this is pretty clear, which we have discussed. I mean, we also discussed about 4 stages in non-communicable disease pathology, the risk factors, then biochemical derangement, then leading to metabolic features, and then those metabolic features later leading to non-communicable diseases. This is simplified and given here. And we did also see this national monitoring framework for non-communicable diseases. WHO in 2013 had come up with a global action plan for control of non-communicable diseases, and it had included about 9 targets. India was the first country in the globe to adapt these global action plan for non-communicable diseases, and included one more target which is specific for India, namely the indoor air pollution related, the one down below in the middle of the slide, which is a 50% relative reduction in the household use of solid fuels as primary source of energy for cooking. So that as one of the targets. I mean, can we try to reduce, because indoor pollution does contribute to COPD and various other related non-communicable diseases. So India included this. If we look at all the other important things, 25% relative reduction in risk of premature mortality from cardiovascular diseases, cancer, diabetes, or chronic respiratory disease. Can we try to bring down the premature mortality? The next one is trying to look at a risk factor, 30% relative reduction in prevalence of current tobacco usage. Similarly, halt the rise in diabetes and obesity. At least a 10% relative reduction in the use of alcohol. A 30% relative reduction in the mean population intake of salt or sodium through various modalities, and a 10% relative reduction in the prevalence of insufficient physical activity. And we did recently see about this indoor air pollution. The next one is 25% relative reduction in the prevalence of raised blood pressure or contain the prevalence of raised blood pressure. I mean, it's not I'm only talking about the risk factors. We also have to provide care. Right? So one of the targets also talks about the care. I mean, 80% availability of affordable basic technologies and essential medicines, including generics, required to treat non-communicable disease once, I mean, people have come to the stage of non-communicable disease, having failed, having we failed to prevent the disease, right? And then also 50% of the eligible people receive drug therapy and counseling to prevent heart attacks and strokes. So the targets try to look at various components. One looks at the mortality and about the epidemic halting the rise in diabetes and obesity. A couple of them also talks about the risk factors, how to address them. And another two talks about the availability of care, preventive care as well as curative care for non-communicable diseases. These are the 10 targets under the National Monitoring Framework for Non-Communicable Disease. Based on these monitoring framework, the country launched national-wide survey known as the National Monitoring Survey for Non-Communicable Diseases, of which our department, Community Medicine Department of AIIMS Jodhpur, was also part of it, trying to undertake the survey for Rajasthan and Gujarat. The data is yet to be out. I mean, it was supposed to be out during March. Because of the COVID, I think it's delayed. So soon we'll be having the baseline data related to all these targets, and then we'll be able to track them over time to see whether we are able to achieve these by 2025. Okay, so the program initially was launched, started very pilot stage in 2008, and then in 2010 it was launched in about 100 districts across 21 states. I mean, one of the important point is this program was implemented in a phased manner as the funds were available. One important thing to be noted here is prior to this launch of the program, the primary health centers and community health centers were primarily dealing with non-communicable diseases and maternal reproductive child health services. Non-communicable disease was not the domain of primary health centers across the country. Those specific states, like for example, Tamil Nadu, had always had provision of non-communicable care at the primary health centers. Though, what quality and what level all varied. So, and then by 2013 and 14, we integrated with the National Health Mission, and it was rolled out in all the 36 states and union territories, and a scheme for tertiary care cancer centers were also initiated. By about 2015-16, almost 470 districts had been approved and started launching these non-communicable diseases. By about 2016-17, almost all the districts, nearly 616 districts were this thing. And by 2018, almost the entire country, every district was supposed to be. But then, you'll have to note here that just because non-communicable, this program has been launched in a particular district, does not mean by 2018 all the primary health center, all the community health centers, or all the health facilities will be implementing this particular program. Even within a district NCD cell is formed, and it was implemented in a phased manner across all the health facilities in a particular district. For example, I was one of the master trainer for Puducherry Union Territory, and when we started this NPCDCS program, it was initially launched in only one particular primary health center. And after that, slowly over the next year, about 4 primary health centers were brought under the program, and slowly it was expanded to include all the primary health centers. So that's how it happens even within a particular district. Even though it says that by about 2018, most of the almost all districts were covered, there also again phased manner it happens. And that's a point here. Slowly it started improving, and by about 2017-18, we did have a whole lot of ICUs and various other facilities across the states. So what is the objective of this program? What is this particular program trying to achieve? Which we had also discussed earlier. One of the important, this tries to achieve 5 objectives. One is, when we try to prevent and control non-communicable diseases, we will have to address different components. First, a component is trying to create awareness related to the impact or the burden of non-communicable diseases, and also try to tell about the various risk factors, what are the various preventive and control strategies available and all that. So creating awareness, trying to raise the attention towards non-communicable diseases, that's a primary objective of this program. Health promotion through behavior change with involvement of communities, civil societies, community-based organizations and media, etc. We have already seen those 4 common risk factors and various other risk factors related with non-communicable disease causation. So trying to do health promotion, which we have seen is the most effective strategy. but does involve important steps. The next stage is once we have created awareness, we also have to screen for presence of non-communicable diseases. So screening at all levels in the healthcare delivery system from subcenter and above for early detection of diseases covered under the program, including management and follow-up. So if we are offering screening, I mean, we'll have to train all the people, make available all the necessary resources for screening. And once people have been screened, obviously people are going to turn up positive for this presence of non-communicable diseases. We should be having capacity to deal with these non-communicable diseases, which I have earlier also, mentioning that primary health centers earlier were dealing more with communicable diseases and maternal reproductive child health related services. So the capacity to deal with non-communicable diseases were apparently lacking. So the third objective is to build capacity at various levels of healthcare for prevention, early diagnosis, treatment, rehabilitation, IEC, BEC, operational research and rehabilitation. So that's the third objective. And the fourth objective is once we are trying to do all this, we have to support these efforts through necessary logistics and resources to provide logistic support for diagnosis and cost-effective treatment at primary, secondary and tertiary levels of healthcare. And very important component which we had discussed even earlier in the theory lectures in non-communicable diseases, that India traditionally did not have data related to non-communicable diseases. All the data came from standalone research studies from scattered across the country. Though we did try in 2007 and 2009 to do a step survey across the country, that again did not cover the entire country or all the states. For example, to the 2009 one, I think covered only 6 states. The 2007 one and 2009 one tried involving IDSP into collection of non-communicable disease-related data. That again did not cover the entire nation. So we traditionally were not having data related to non-communicable diseases. So to obtain data related to non-communicable diseases so that we can frame our prevention and control strategies appropriately or specific to a particular population is very important. So the fifth objective of this particular program is to support for development of database of non-communicable diseases through surveillance system and to monitor non-communicable disease morbidity, mortality and risk factors. We did just a few minutes earlier see about the various targets, right? The 10 targets to be achieved by 2025. How are we going to know whether we are progressing towards those targets, or how are we knowing that we have achieved those targets? So we need data for that, and the data will be drawn from through different modalities. One being the routine programmatic data being collected through the program. The second one is the national monitoring survey, which I was talking to you a few minutes back. So just a minute. So the various strategies with this national program adapts is health promotion through awareness generation and promotion of healthy lifestyle, screening and early detection, timely, affordable and accurate diagnosis, access to affordable treatment, rehabilitation. These are some of the strategies which this program will be adapting to provide preventive and control or curative care through the program. So these are the various program components: prevention through health promotion, screening and early diagnosis, case management, supervision, monitoring and evaluation, which is common for any non-communicable program. And we did also talk about the capacity building, because traditionally we were not dealing with non-communicable diseases. So capacity building in form of infrastructure, human resources, training and logistics. So this is how the national health program roughly looks like. There's a national NCD cell at the ministry level, and each state is supposed to have a state NCD cell, and in each district again a district NCD cell. Under the district NCD cell, there will be a program officer and a couple of other people. In every district, There will be a district non-communicable disease clinic. There will be a cardiac care unit, daycare cancer center. Apart from this, there will be all the all the CHCs will have a non-communicable disease clinic, and PHCs will be doing the prevention and screening related activities, both at the primary health center and subcenter level, identification, early diagnosis, and referring them to CHCs. And all those with severe complication and needing more intensive care will be referred to the district clinic and these cardiac care units or daycare cancer centers. So at the district NCD level, these are the program, and there will be a program officer, program coordinator, finance logistic officer, data entry operator, roughly, and under each district cell. So the various activities at each level, at the primary health center level and the sub-center level, it will be more of health promotion IEC activities, screening for non-communicable diseases and common NCDs, non-communicable disease risk factors and common NCDs, case management at PHC if a MO is trained and if is in position, and referral to nearby health facility or CHC if whenever needed. At the community health center level, diagnosis and management of common non-communicable diseases, referral of complicated cases, the health promotion including counseling, data recording and reporting will all be done. And at the district level, diagnosis and management of non-communicable diseases, referral of complicated cases, cardiac care unit, daycare center, health promotion activity and all that, right? So at the primary health center level, the main focus is on the health promotion activities for lifestyle changes. Various activities will be taken up by the primary health center and sub-center staff. And specifically at the sub-center level and in the community, outreach activities and health camp will be conducted. Health camp is considered as one of the important combined activity for raising awareness as well as for screening under this program. So at the moment, earlier we used to offer opportunity screening under the non-communicable disease program. So anyone who walks into the health facility, sub-center or primary health center or communicable health center or district hospital at any or tertiary care center, wherever a person walks into the health facility for any related health complaints, they will be offered non-communicable disease screening, and they will be asked to undergo non-communicable disease screening, and risk assessment will be done, and appropriately risk counseling or risk management will be done. That used to be the strategy. But we felt, the program later realized that this is not effectively reaching everyone. So slowly, with more resources being made available to the program, this initiative was further extended into universal non-communicable disease screening, which is also called as a population-based non-communicable disease screening. So in this particular initiative, a frontline health worker or the health, a frontline worker or health worker, which is ASHA and the AIIMS team, will screen all person aged more than 30 years of age in the community for non-communicable risk factors and presence of common NCDs, and refer them to the primary health center or CHC for appropriate management. So one of the important thing to be noted here is the age cutoff for which is used in this NPCDCS, both for opportunistic screening as well as population-based NCD screening, is any person above 30 years of age, right? So we'll further look at this particular activity in detail. And the data being collected at this level is filling up of family folders at community level, maintaining registers at the sub-center primary health level, and monthly reporting of data related to whatever activity which are ongoing. Under this program, the ministry has approved one additional staff nurse to be used for non-communicable disease screening. So many at different states, either people recruit one staff nurse or use this money to recruit 2 AIIMS or 1 AIIM and 2 ASHAs. It differs from state to state, but one position for staff nurse, so much money is provided through the program to the states for every primary health center level. So at the community health center level, opportunistic screening for persons still continue to happen, and promotional health lifestyle, healthy lifestyle through health education continues to happen. And management, diagnosis, management, counseling, rehabilitation service related to NCDs, and referral of cases and various maintenance of various records are made available. Under this particular program, contractual manpower for one medical officer, one staff nurse, one counselor who can undertake NCD risk assessment and risk counseling appropriately for lifestyle modifications and other risk reduction strategies, one laboratory technician for various investigatory support, and one data entry operator is provided in the program. At the district level, again, opportunity screening continues to be happening. Promotion lifestyle through health education continues to happen. And in the care level, I mean, detailed investigations for all the non-communicable diseases are made available. Wherever those services not previously existing, they are outsourced. And outpatient and inpatient care for those requiring inpatient services are also made available. CCU to manage acute emergency CVD cases are done. There is a ongoing coordination with the ambulance services to bring in people for early management is also taken up under the NPCDCS. And daycare chemotherapy facilities also made available at every district hospital level. And wherever needed, referral and transport facility to nearest tertiary care and tertiary care cancer treatment centers are also made. And under this program, the various manpower made available are at the district NCD clinic, one physician trained in non-communicable diseases, staff nurse, counselor, physiotherapist, laboratory technician, and DU. And in the CCU, one cardiologist and 4 nurses are made available. Okay, so this is how the structure looks like, and various reports are sent, various forms and reports are sent across the network to reach the national level by every 15th of every month, right? I mean, we will look at these forms later when you come for the clinical posting. So, okay. So, this is how the service in this thing. So, I mean, initially we were providing this opportunistic screening, which is like this iceberg, and we wanted to capture the base of the iceberg. So we proceeded with the population-based screening. So we'll, just move away from the slide for a moment and try to look at how this particular screening is done, right? I'll open I'm opening a PDF, a particular page from the operational guidelines for prevention, screening, and control of common NCDs. I mean, you'll be able to see this CBAC checklist, Annexure 1, community-based assessment checklist, CBAC for early detection of non-communicable diseases, right? Are you able to see? I mean, if you are not able to see, please do mention it in the chat box, so I'll be able to reproject it. So this is, a simple checklist which is used by, thank you, Satvik. So this is a simple checklist. So the team at the population level, at the subcenter level, consists of one ASHA and one ANM, right? I mean, as per the program, though it varies from state to state. People, for example, in Pondicherry, they have not had ASHA. They are utilizing only ANMs. Similarly, in different states, different model is used. But as per this program, one ASHA and one ANM are supposed to be involved for this population-based screening. So this ASHA will go around this village. She will try to create a family folder, trying to enlist all families in a particular village. And then within every family, she will try to identify all those adults aged above 30 years or more, and she will enlist them. And once she has enlisted this particular beneficiary list, she will fill up this particular form. This is called as a CBAC checklist. It has identification details and a small risk assessment tool. These are very simple questions which does not require major technical capacity. So the first question is, what is your age? She tries to ask the age and categorize them, and a score is given for each category, 0, 1, 2. And then the next question is, do you smoke or consume smokeless products such as gutka or kind? So we know tobacco usage is an important risk factor. So Again, the responses are obtained and scored. Next one is, do you consume alcohol daily? So this is just about history of alcohol usage. I mean, here we are not trying to quantify them, trying to define them as harmful use of alcohol or alcohol dependence, all that. Just about a history, whether the person consumes alcohol daily or not. And a very important metabolic risk factor or a parameter is the waist circumference measurement. So the waist circumference will be measured and scored here. Another important question, another important thing we know is the physical activity. So do you undertake any physical activity for a minimum of 150 minutes in a week? So again, the responses are obtained and scored. Right. There is one more question asking about the family history. Do you have any family history, any one of your parents or siblings, that is like immediate, of high blood pressure, diabetes, heart disease? So trying to assess the family related risk here and trying to ask yes or no and then score. So once all these scores are obtained, the total score is calculated, and if the score is 4, this person will be prioritized for the non-communicable risk screening to be done by the AIIMS. It does not indicate that anyone above 30 having a score less than 4 will not be screened. It only means that anyone having score more than 4 will be prioritized for screening faster than a person who's having a score less than 4. But as per the program, everyone above 30 years have to be screened for non-communicable diseases. In addition to this part A of the risk assessment, since we also have cancer prevention and control under this program, there is another part B of this CBAC checklist for early detection of cancers. So in both men and women, all these symptoms will be asked: shortness of breath, coughing more than 2 weeks, blood in sputum, history of fits, difficulty in opening mouth, ulcers, patch, growth in the mouth that has not healed in 2 weeks, any change in the tone of your voice, all this. And and for specifically for women, lump in the breast, blood-stained discharge from the nipple, change in shape and size of the breast, bleeding between periods, bleeding after menopause, bleeding after intercourse, and foul-smelling vaginal discharge. Oh, this gone up. So this particular checklist tries to ask whether these symptoms or signs are present in a particular male or female, and then if present, nothing will be done. They'll be directly referred to the medical officer for further management, right? So this will be filled up, and then all these people will be referred to the AIIMS. So AIIMS will organize a non-communicable screening camp every month. A minimum of 30 members have to be pooled in a particular village, fitting the criteria, that aged more than 60, and priority will be given for anyone having scored more than 4 in the part A of the checklist, and anyone reporting these symptoms again also will be prioritized for NCD screening by the AIIMS. And every month there will be one camp per village, and at least 30 members have to be asked to attend this camp. So this will be conducted as close as possible to the village in any facility where privacy and the examination can be conducted. The feasibility will be explored by the AIIMS and will be conducted. So in the NCD camp, the AIIMS will undertake blood glucose measurement, will undertake blood pressure measurement, will have a detailed NCD risk counseling in form of tobacco usage, alcohol usage, vegetable consumptions, various other things. Will measure the various NCD parameters, height, weight, BMI assessment, waist circumference, waist hip ratio, and all that, various other things. We will also do detailed screening of oral cancers, breast cancer, and cervical cancer for male and female respectively. And anyone found having any deviation or anyone found to have non-communicable disease will be referred to the medical officer or the primary health center. If he or she is present and trained, they will be further confirming it and referring them to the CHCs for further confirmation and detailed workup, because laboratory support is often available at the CHC level. So for the first time after the initial verification by the medical officer, they will be referred to the nearest community health center, where detailed examination will be done, and they will be appropriately either referred or referred back to the primary health center for management. And anyone found to have cancer will be referred to the cancer center at the district level, and they will be further worked up. So this is how this particular process happens in the community. Okay, I'll shift back to the slides again. There are detailed manuals available for this NCD risk management, screening, and various modalities. I'll share them in your Google Classroom after this session. So apart from this major activity, which is the universal NCD screening or the population-based screening, which again was started only in the year 2018, and now slowly getting extended in a phased manner across the entire NCD network in the country. And then the other recent initiatives under this NPCDCS program is inclusion of COPD and chronic kidney disease interventions under the program. And it is also trying to integrate or converge with other health programs. For example, collaboration with the RNDCP for tuberculosis, diabetes, comorbidities, which we'll see in detail in a couple of minutes. Collaboration with the RBSK, which is the school health program, right? I mean, for pilot intervention on prevention and control of rheumatic heart diseases. You might recall from your previous theory discussions that rheumatic fever is common among the childhood and early adolescence, which leads to rheumatic heart disease later and on. So we're trying to prevent all the pharyngitis and trying to put them on different preventive strategies. All involves school health. So this NPCDCS collaborates with the program for the school health RBSK and has launched this pilot intervention on prevention of control of rheumatic heart disease. And it is also working with the AIIMS ministry and various AIIMS related agencies for bringing in the best possible preventive as well as curative care regimens in the AIIMS into the NPCDCS management guidelines. And it's also trying to converge with the National Urban Health Mission for provision of NPCDCS care, prevention and control care across the urban areas. It is also integrating with the other health programs on the anvil, namely the mental health division for gestational diabetes, the mental health program for comorbid mental health disorders, whether a joint screening can be done. So this universal health NCD screening, which we had seen, just now, so it involves screening of population. Just repeating it for sake because this is a very important area. Screening of population above 30 years of age by the frontline worker, ASHA and ANM. ASHA to fill up the community-based assessment checklist, CBAC, and family folder to capture the demographic data, risk behavior data, and simultaneously impart health education about a non-communicable disease screening and preventive measures. ANM and mid-level healthcare provider trained will do the blood pressure measurement, blood sugar measurement, oral visual examination, clinical breast examination, and in addition, the nurse will perform visual inspection using acetic acid, VIA, for cervical cancer screening. So this is a rough pictorial representation of what happens, which I had discussed earlier. You can have a look at it when I share the slides later with you. So some of the challenges in this universal NCD screening is availability and functionality of the physical infrastructure, logistic available, NCD drugs and diagnostics at health facility, mapping and referral networks for health facility for NCD services for screening, diagnosis and treatment, availability of manpower in these facilities, capacity building at different categories of health staff, plan for fund utilization, monitoring, supervision for this thing, various other things. So not going into much detail. One of the important challenge is, we are expecting the ASHA, the ANM to do a huge work, right? I mean, we are asking them to do a risk assessment. We are asking them to do screening for cancers, screening for non-communicable diseases. So whether this capacity exists or not is a question. So important initiative under this program is to train the field staff or the frontline workers as well as the team in the primary health center and community health center to smoothen this process for providing all the appropriate training. So whenever this universal NCD screening is phased out or implemented in every, so phased in or implemented in the in every district, PHCs will be identified and all the AIIMS and ASHA and the various staff will be made to undergo this training. They will be taught these specific skills about how to do oral examination for cancer, how to do breast cancer screening, how to do VAA. All this training will be provided, only then it will be implemented. Right, okay. There is also this initiative for the COPD intervention. So at the primary care level, patient reporting with respiratory symptom, and they will be, if they are having age more than 35, presence of exposure to risk factors of COPD, and symptoms suggestive of COPD, namely the breathlessness with wheezing, chronic cough with expectoration, with or without physical signs of COPD, and absence of features of alternative diagnosis. They will be, obviously, if anyone reporting cough or similar system, first will be screened for tuberculosis. If they are, found positive for tuberculosis, they will be put on RNTCB, DOT therapy under the RNTCB. If they are negative, then provisional diagnosis of COPD is made. And with the provisional diagnosis of COPD, assessment of severity based on history of previous exacerbations, severity of symptoms, presence of complications, severity of hypoxia, presence of comorbidities, all that will be. So they will be initially empirical therapy will be started. They will be referred to the community health center for spirometry and confirmation of diagnosis, and where they will be reassessing the severity of COPD based on the results of spirometry. If they are mild or moderate COPD, they will be initiated on treatment according to guidelines and put on follow-up at the primary health center level. And if they are having severe COPD, they will be referred to the district hospital or the nearby medical college for optimization of the therapy, and will be put on follow-up at the primary health center, at the community health center level. So again, all these important challenges definitely are there. I mean, provision of equipment, consumables, example spirometry, capacity building for COPD diagnostic and management, specialists, pulmonologist consultation, referral network has to be mapped, and data on all that are important. Again, chronic disease intervention is also being taken up under the NPCDCS program. Provision of 4 hemodialysis machines per district hospital is being provided under this program. Provision of specialist nephrology consultations and collaboration referral network is expected to be done under this initiative, and data are to be done. So the mechanism of collaboration is the Pradhan Mantri National Dialysis Program, which is a separate parallel initiative which came up. So for provision of dialysis machines and hemodialysis services under the PPP model. So there will be a collaboration between the NPCDCS and this Pradhan Mantri National Dialysis Program to obtain and create and maintain these dialysis machines and chronic kidney disease services at each district hospital level or district level. Okay, one of the important things we had earlier seen in non-communicable disease discussions, and also possibly in primary healthcare lecture which we earlier had in April. So one of the 4 principles of primary healthcare is intersectoral coordination, right? And we also know in non-communicable disease that these risk factors, common risk factors, physical activity, tobacco consumption, alcohol, harmful use of alcohol, diet, all are not directly within the control of health ministry or the health sector. Each of them have contributions from various ministries and various sector for control or trying to alter the behavior, right? So important thing needed in non-communicable disease is this multi-sectoral action, which is important. So under this program, a separate unit has been formed in the ministry, and IAS level officer, possibly at the level of joint secretary, has been given in charge for this nodal agency. Establishment of platform for multi-sectoral collaboration and attainment of commitment to health in all policies. So this particular unit tries to look at all the government actions from various ministries, their policies, their act, their interventions, and try to indicate to them what is needed for health promotion and health prevention and control of non-communicable diseases. Right. So, for example, health promotion. This particular nodal agency tries to look at the reduction of risk factors, unhealthy diet, physical activity in children and adults. It also tries to do health system strengthening by ensuring NCD services under universal health coverage, surveillance monitoring, and all that. Various things are being undertaken by this multi-sectoral plan. Maybe we'll discuss them in detail at a subsequent opportunity. So it tries to collaborate with various people, I mean, state, government ministries, private sector, civil societies, international partners, community, trying to do all the prevention and control activities of this thing. Apart from this, we also saw that NPCDC is trying to integrate or converge with the other health programs or other health platforms. One is NPCDCS with NUHM, RNTCP, maternal health, AIIMS, which we have earlier discussed. So this is again possible areas of integration for NPCDS with other programs is slowly being taken up by NPCDCS. For example, if you look at the very last one, under the initial immunization program, hepatitis B vaccination for hepatocellular carcinoma prevention. HPV is slowly coming up, though the initiative was blocked because of the various unethical practices related to the HPV vaccine trial which happened in India. So slowly, once all this controversies settle down, HPV can be used as an important initiative for prevention of cancer cervix. I mean, various other things can be done, right? So that is possible, and so you can look into all of these when I send the slide. I am very particular, I mean, wanting to talk about this particular aspect, integration of NPCDCS with RNTCP. So earlier you might have already known about the integration between RNTCP and NACO. Sorry, NACP, National AIDS Control Program, right? Where we do have a particular thing called as bidirectional screening. For every patient diagnosed with tuberculosis, we'll be screening them for HIV. And for every patient diagnosed with HIV and AIDS, we will be screening them for tuberculosis, which we clearly know that these are comorbidities of each other, and the presence of this comorbidity tries to put the treatment and the health of the particular, I mean, a person with tuberculosis or a person with HIV in the presence of the other, I mean, more. So same way, we also know, I mean, the literature very clearly indicates that this tuberculosis and diabetes as comorbidities can affect each other and their treatment success. So diabetes can worsen the clinical course of TB, and TB can worsen glycemic control in people with diabetes. So here also the same strategy of bidirectional screening can be adopted. So this national strategy for bidirectional screening for early detection and better management of tuberculosis and diabetes comorbidities was launched in the year 2014. In 2012, there was an international effort from the union and various other organizations trying to push for it. And India again was one of the first few countries to adopt this and implement. And in 2014, both the program RNTCP and NPCDCS came together and said, we will do bidirectional screening. So guidelines, I mean, further detailed guidelines have been launched in the year 2017. And in this particular thing, for every patient diagnosed with tuberculosis, diabetes screening will be done as part of the routine investigation panel. And in high prevalence states of tuberculosis, all diabetic patients will be screened for tuberculosis periodically as they come for chronic follow-up care, right? So, and IEC will be done both through these programs to highlight the importance of synergistic effect between tuberculosis, diabetes, and the need for bidirectional screening and controlling both these comorbidities. So, so in bidirectional screening, diabetes with one or more symptoms of TB symptom complex to be referred to the near DMC for TB diagnosis. And TB patients with the RBS more than 140 or known history of diabetes to be referred to the NCD clinic for the better glycemic control and continuation of therapy. So this is one important area which is happening. And similarly, similar integration is possible for gestational diabetes also. and various other integrations are given. I'm skipping them. I mean, with the idea that you'll be going through these slides at a later stage to. So much for the very quick brief about this non-communicable disease program. I mean, during the 7th semester clinical postings, we used to often have hands-on training for risk assessment and utilizing the various protocols under the NPCDCS. But unfortunately, this time, because of the COVID, we have lost these clinical postings in the Pratap Nagar and various centers where we used to give, I mean, this risk assessment hands-on. Maybe at a later stage, if possible, if there is a feasibility and time availability, we will try taking up this. So I'll also be sending the operational guidelines manual and various other resources to you, either to this Google Classroom, Classroom portal, or through WhatsApp to your friends to be shared with your group. So you can have a detailed look at these manuals and various resources to have a detailed idea about this NPCDCS. So one of the structured long question which comes in your exam will be related to how do you go about screening, how do you go about doing risk assessment, and how do you plan for the prevention and control of non-communicable diseases under this NPCDCS program and all that. So you can have a detailed look. Okay, so much for the brief overview of this program. If you have any doubts, do ask them in the chat box or feel free to call me.